Hello dear viewers, today in this video which is part 1 on nutrition support in critically ill adults, I will discuss the whole spectrum of nutrition support in critically ill adults spanning multiple videos over ensuing months. Consider nutrition as a part of therapy for critically ill adults rather than simply a supportive management because it impacts the outcome. I am Dr. Sunil Garg from Essentials of Acute Care. Nutrition support refers to the enteral or parenteral provision of calories, protein, electrolytes, vitamins, minerals, and trace element and fluids. Here it is important to note that I did not mention carbohydrate and fat separately since it falls under calories while protein is not. The phases of critical illness include the acute, which is further divided into early and late and chronic phase. The early acute critical illness is characterized by catabolism, exceeding anabolism, heightened inflammation, hyperglycemia, and proteolysis. My presentation will focus on nutrition during the early acute phase of critical illness. In general, oral feeding is preferred over enteral support and enteral feeding preferred over parenteral support. Enteral feeding is common mode of nutritional support unless contraindication exists. It is important to understand that critically ill patients represent a heterogeneous population and that the timing, dose, prescription and titration of nutrition varies. My presentation will focus for the typically critically ill patients. In the initial evaluation of patient regarding nutrition, assess the patient's nutritional status, need for nutritional support, and the presence of any contraindication to select modes of delivery. Patients with wasting due to starvation are malnourished and they are responsive to nourishment. While wasting due to catabolism is common in critically ill adults, patients with wasting solely due to catabolism are not malnourished and are not responsive to nourishment. However, patients with catabolism are also more likely to have starvation due to feeding difficulties like gastrointestinal dysfunction, anorexia, and may also be malnourished. The evidence that patient has malnutrition includes poor nutritional intake, which is accompanied by unintentional weight loss or low body weight. For example, a BMI less than 18.5, unintentional loss of more than 2.3 kg or 5% of body weight over 1 month, or unintentional loss of more than 4.5 kg or 10% of body weight over 6 months. Other evidence includes muscle wasting like temporal muscle wasting, shrunken supraclavicular foci, scaphoid abdomen, decreased adipose stores, and signs of vitamin deficiencies. The precise duration necessary for malnourishment to develop is unknown and probably varies among patients. As a general guideline, it is reasonable to assume that starvation-related malnutrition is impending in any patient who has had little or no nutritional intake for 2 weeks. For patients with antecedent undernourishment, 1 week or less may be more accurate. Inflammation-related malnutrition may develop indolently but may also develop in hours to days with severe illness. Thus, reassessment of nutritional status is important during critical illness. Since malnutrition is poorly defined terminology, many experts have encouraged using the concept of nutritional risk, which is again loosely defined as a risk of acquiring complications because of undernutrition, such as nosocomial infections, poor wound healing, prolonged mechanical ventilation, and death. Nutritional risk considers both patient and disease-related factors, but nutritional risk scores have not been validated to predict response to nourishment in critically ill. Although nutritional chemistries are often measured and are prognostic indicators of poor outcomes, such surrogates particularly reduced serum proteins like serum albumin, prealbumin, transthyretin are non-specific and should be assumed to be due to systemic inflammatory critical illness. In addition, they are not responsive to nutrient intake and therefore cannot be used as therapeutic biomarkers. Regarding the assessment of the need for nutritional support, the adequately nourished patient who are expected to be extubated within 24 to 48 hours of admission and are likely able to eat after extubation typically do not need enteral or parenteral support since oral nutrition is considered optimal. But when mechanical ventilation is expected beyond 48 hours, nutritional support is needed and typically enteral support is required unless contraindication exists. When contraindications are expected to persist, consider parenteral support in such patients. The contraindication of enteral nutrition includes if patient is in hemodynamic instability leading to shock. Full enteral feeding should be avoided during initial periods of resuscitation. But if there is evidence for adequate volume resuscitation and tissue perfusion, hemodynamic instability by itself, unless severe, is not a contraindication for enteral nutrition. Similarly, enteral feeding does not necessarily need to be stopped for transient, mild periods of hemodynamic instability, which can commonly punctuate a patient's course during critical illness. Recurrent, unnecessary holding of tube feeding can result in large calorie deficit and should be avoided when possible. Other contraindications to enteral nutrition include bowel obstruction, severe and protracted ileus, major upper gastrointestinal bleeding, intractable vomiting, evidence of gastrointestinal ischemia, high output gastrointestinal fistula, and abdominal compartment syndrome. Here it is important to note that minor upper gastrointestinal bleeding is not a contraindication to enteral nutrition. Some conditions previously considered contraindication to enteral nutrition are no longer considered as such. Examples include hyperemesis gravidarum and the absence of bowel sounds or flatus following routine colorectal surgery or surgery for bowel perforation. In addition, a new gastrointestinal anastomosis distal to the infusion site that the surgeon feels are at risk of dehiscence was once considered a contraindication until data indicated that early feeding strengthens the anastomosis. Whether this applies to all anastomosis is unknown, and when the anastomosis are felt to be tenuous, like in gastric bypass surgery, defer to the surgeon's judgment as to whether enteral nutrition should be started. High gastric residual volume is not an absolute contraindication to enteral feeding, although holding feeding when a residual volume are more than 500 ml is acceptable. In terms of contraindication to parenteral nutrition, it includes uncontrolled hyperglycemia, uncontrolled electrolyte abnormalities, intravascular volume overload, inadequate intravenous access, and inadequate attempts to feed enterally. Here I finish and I will continue with the same topic in my next video. If you have any feedback, suggestions or comments, please write down in the comment section. Till then, bye and take care.